All right, today we're going to talk about case control study of risk factors for GME in dogs. This paper is out of JAVMA from 2019. I have not seen this paper before, so I'm looking forward to it. Let's get started.
Case control study of risk factors for granulomatous meningoencephalomyelitis in dogs. Objective: to identify environmental and other variables associated with the diagnosis of granulomatous meningoencephalomyelitis in dogs. Design: case control study. Animals: 31 dogs that received a histologic diagnosis of GME from January 2003 to January 2014, and 91 aged breed-matched dogs. Procedures: data were obtained from each dog's medical records regarding home address, signalment, body weight, body condition score, vaccination history, and date of diagnosis or visit. Home address data were used to determine the human population density in each dog's geographic region. Seasonal distributions of GME diagnosis in the case group were evaluated for differences. Case and control dogs were compared with respect to the remaining variables. Results: for case dogs, no significant difference was identified among seasons in the distribution of GME diagnoses. However, such diagnoses were more common in the spring than in other seasons. No significant differences were identified between case and control dogs in age, body weight, BCS, human population density, season of diagnosis or visit, or time of the last vaccination. Although females appeared more likely than males to have a GME diagnosis, this association was not significant and did not change when BCS, time since last vaccination, or human population density was considered. Conclusions and clinical relevance: none of the evaluated factors, including investigated environmental triggers, were associated with a GME diagnosis in the dogs of this study. Additional research is warranted involving dogs from a broader geographic area.
All right, so nothing surprising there, as GME seems like it can happen any time of year, and as far as when it occurs, it seems kind of random. I get why they were looking at vaccinations, because there's definitely times where we have dogs with a fairly recent history of vaccines that is diagnosed with a new onset of GME. But again, we have plenty of dogs that develop this condition, at least what we diagnose as GME, that have no history of getting recent vaccinations. I would be curious if there was anything investigated as far as recent infections, because at least in people with Guillain-Barré syndrome, and then some patients, some dogs that have polyradiculoneuritis, have a history of recent infection, whether it's aspiration pneumonia or Campylobacter, that there might be a predisposition for polyradiculoneuritis. But it doesn't look like that's looked at here, but we shall see. We'll get into it.
Granulomatous meningoencephalomyelitis is an inflammatory disease of the CNS that has been identified in dogs of various ages, breeds, and sexes as associated nervous system lesions may be focal or multifocal. The cause of GME remains unknown. However, infectious agents, toxicants, and environmental factors have been suggested. Because no causative infectious agent has been identified, it is considered likely that GME is an immune-mediated disease triggered by genetic or environmental factors, or both. Environmental triggers have been explored for other immune-mediated diseases, such as IMHA and SRMA in dogs. Some reported findings suggest a link between IMHA and infectious, neoplastic, or inflammatory processes or vaccine exposure. On the other hand, no association was found between SRMA and vaccination, season, geographic location, or dog sex in one study, but a significant association was identified between SRMA and specific breeds. It is therefore suspected that genetic factors may predispose an individual dog to the development of GME. However, specific factors may then be needed to trigger the onset of disease. The purpose of the study reported here was to determine whether sex, body weight, BCS, vaccination history, season of onset of clinical signs, and human population density in the dog's geographic area were significantly associated with the diagnosis of GME in dogs. Materials and methods. Animals. A case control study design was used. The medical database of UW Veterinary Care, the Veterinary Teaching Hospital at the University of Wisconsin-Madison, was searched to find all dogs that received a histologic diagnosis of GME from January 1, 2003 through December 31, 2014. Results of histologic examination were reviewed, and the diagnosis was confirmed by a board-certified veterinary pathologist prior to inclusion in the study. The diagnosis of GME was made on the basis of standard diagnostic criteria, as described elsewhere. Dogs were included in the case group if histologic findings were consistent with GME and complete medical records were available for review. The medical records for the same period were also searched to identify 3 control dogs matched to each case dog by age, breed, and year of the visit to the teaching hospital in which they qualified for inclusion. For mixed breed dogs, control dogs were matched to case dogs on the basis of apparent predominant breed, as recorded. Control dogs were excluded if they had been evaluated for neurologic disease, had a history of neurologic disease for which a neurologist had been consulted, were receiving anti-seizure or immunosuppressive medications, or died on arrival at the hospital and no necropsy was performed. If insufficient control dogs meeting these criteria were identified to match to a given case dog, more control dogs were identified by expanding the allowable age difference or evaluation year. Data collection. Data were obtained from the medical records.
One thing it is worth noting, at least from what it looks right now, is that all cases came from the University of Wisconsin. So there's going to be some bias in their population, as maybe the patients that they're seeing, the environmental exposures, diseases in that area is going to differ compared to, say, somewhere in Georgia or Texas. So just something to keep in mind.
For dogs in both groups regarding age, sex, body weight, BCS, and home address at initial diagnosis or the visit of study inclusion, as well as the date of the most recent vaccination prior to or including the visit of study inclusion. Body condition was recorded on a 9-point scale, with score 6 considered overweight. If no BCS was recorded but subjective assessment data were available, dogs recorded as in good, fair, or excellent body condition were classified for the study as having a BCS of 5, dogs recorded as in thin body condition were classified as having a BCS of 3, and those considered overweight or having excess body habitus were classified as having a BCS of 7. For control dogs specifically, if no BCS was recorded at the visit of study inclusion, the BCS from previous visits was used provided no change in body weight had occurred since that time. The referring veterinary hospital was contacted to obtain any missing patient information, and unavailable data were omitted from statistical analysis. For study purposes, the season of the visit of study inclusion or onset of clinical signs was classified as winter, spring, summer, or fall. If the date of onset of clinical signs was not recorded for case dogs, the date of necropsy diagnosis was used instead. Human population density within the dog's geographic area was determined by conversion of the home address to longitude and latitude coordinates by use of an online resource. The human population density for the 5 square miles surrounding these coordinates was then determined by use of an online population calculator. The time between onset of clinical signs or date of visit and most recent vaccination was calculated and categorized as 1 month, 6 months, and 12 months from the onset of clinical signs. Statistical analysis. Associations between case control status and the various potential predictor variables were explored by means of conditional logistic regression, with matched pair status as a stratum variable. The p-values pertaining to these models were computed by use of the likelihood ratio test. Odds ratios were computed as estimates of effect size. For categorical predictor variables, the OR was calculated relative to an arbitrarily chosen referent category. Distributions of dogs in the case group were compared among seasons of onset of clinical signs by use of the Fisher exact test. Several conditional logistic regression models were fit that contained multiple predictor variables. However, because the results were similar to the results of univariate analyses, no results of multivariate modeling are shown. All statistical analyses were performed with the aid of statistical software. Values of p 0.05 were considered significant. Results: 38 dogs with a
Just real quick, again, the purpose of this study is to report and determine whether sex, body weight, body condition, score, vaccination history, season of onset of clinical signs, and human population density are associated with GME. And looking at how their study is set up, I think it's very well designed. But again, this is only for the population around the University of Wisconsin.
Histologic diagnosis of GME met the criteria for inclusion in the case group. 7 of these dogs were excluded because of incomplete medical records or disagreement with the initial diagnosis when reviewed for inclusion, leaving 31 dogs in the case group. 3 control dogs were identified for each case dog, except for 1 case dog for which only 1 control dog could be identified, resulting in inclusion of 91 dogs in the control group. Case dogs. Median age at onset of clinical signs of GME for the 31 dogs in the case group was 6.2 years, and median body weight was 8.3 kilograms. Median BCS on a 9-point scale for the 29 dogs for which it could be determined was 5. 12 dogs were male, and 19 dogs were female. Dogs included 7 mixed breed dogs, 4 dachshunds, 2 pugs, 2 shih tzus, 2 Labrador retrievers, 2 golden retrievers, and 1 each of various other breeds or breed mixes. For the 24 case dogs with available information, median time from the date of last vaccination to the onset of clinical signs of GME was 212 days. Control dogs. Median age of the 91 dogs in the control group was 7.0 years, and median body weight was 10.4 kilograms. Median BCS of the 81 dogs for which it could be determined was 6. 40 dogs were female, and 51 were male. For 10 control dogs, the age range for matching to case dogs needed to be expanded to allow matching by breed. For the 91 dogs with available information, median time from last vaccination to the visit of study inclusion was 235 days. Statistical analysis. Month and season of onset of clinical signs of GME were fairly evenly distributed within the case group, with no unequal distribution identified among seasons. No significant difference was identified between case and control groups. Aggregating age, body weight, BCS, or time of the last vaccination. The odds of a GME diagnosis did not change with human population density. Although females appeared more likely to have a GME diagnosis than males, this association was not significant. This relationship did not differ after controlling for BCS, time of last vaccination, or population density.
The p-value for the sex difference is 0.06, so although it's not 0.05, there's definitely a trend in the direction that it's more common in females, which is common with people that have multiple sclerosis. And I would say, at least from my clinical experience, I tend to find GMEs more common in females. But again, in this study, it wasn't significant, but they're only looking at 31 dogs here.
Discussion. The purpose of the present study was to determine whether dog sex, body weight, BCS, time of last vaccination, season of onset of clinical signs, or human population density was significantly associated with the histologic diagnosis of GME in dogs. None of these variables, including the evaluated environmental factors, were associated with a GME diagnosis. A potential female predilection for meningoencephalomyelitis of unknown etiology and IMHA in dogs has been reported, but not for immune-mediated diseases such as SRMA. Although female dogs appeared more likely to have GME than male dogs in the present study, this association was not significant. Whether this lack of association was attributable to a low sample size and related low statistical power remains unknown. A sex predilection, if it existed, could suggest that the presence, or proportion, of various amounts of androgens may influence the development of immune-mediated disease. The possibility of a complex interaction between sex hormones, X chromosomes, and the development of GME should be explored in future research. Dogs with a PCS6 had no greater odds of a GME diagnosis than dogs with a PCS5 in the case control study reported here. Although no causal associations can be identified through observational studies, this finding suggested that overweight and obesity were not associated with GME. However, whether obesity specifically is associated with or contributes to GME remains to be determined. Vaccination has been suggested as a trigger of autoimmune disease in dogs, although whether such an association exists is controversial. In one study, significantly more dogs developed IMHA within 1 month after vaccination than control dogs. Conversely, in a case control study, vaccination within 6 weeks prior to onset of clinical signs of SRMA or the visited study inclusion was not associated with an increase in the odds of the disease. Similarly, the present study revealed no association between the time of last vaccination, as categorized, and a GME diagnosis, providing no evidence to support client concerns about a temporal association between these two variables. No association was identified between human population density and a GME diagnosis for the dogs of the present study. However, caution is warranted in interpreting this finding given that dogs in low density areas may still have had exposure to higher density REs and vice versa, confounding the results. Additional studies should be performed with dogs restricted to rural or urban environments to avoid this limitation. No seasonal trend was identified in GME diagnosis. In the present study, although in a previous study, more dogs had onset of IMHA during the spring and summer in California than during the fall and winter. Multiple sclerosis in humans and autoimmune encephalomyelitis in mice are immune-mediated CNS diseases that have been extensively investigated for potential environmental triggers. Exposure to UV radiation is suggested to be protective against development of both conditions owing to activation of regulatory T cells and induction of anti-inflammatory cytokines. Higher versus lower exposure to UV radiation is associated with a reduced incidence of multiple sclerosis and experimentally induced autoimmune encephalitis, and a significant decrease in the incidence of multiple sclerosis has been identified at low latitudes, although no significant association with season was identified for the dogs with GME. In the present study, exploration of the amount or rate of exposure to UV radiation may be worthy of further investigation. Limitations of the present study included those inherent to all retrospective studies, such as reliance on previously recorded data that may have been inaccurate or incomplete, as well as the subjectivity of BCS recording, the small sample size, and the restricted geographic range of included dogs. Furthermore, the small numbers of dogs in various categories precluded inclusion of all predictor variables in one model, which would have been ideal. Although effort was made to ensure dogs with a diagnosis of GME truly had the disease, errors in diagnosis were possible as well.
On that note, as far as the way that they diagnosed it, they said that they use what's recommended in reference 11. And looking at reference 11, it's the veterinary neuropathology book from Summers and De La Junta. And that's from 1995, but basically they had to get histopathologic diagnosis, which is probably why they only have 38 dogs in this group. So I think they could have increased their numbers if they would have done presumptive diagnosis of GME as well, and maybe separated out the groups. But that said, probably the best way to design the study to confirm the diagnosis of GME is what they did. So I applaud them in that, as it is very difficult to get an owner to agree to get a brain biopsy on a dog with GME. Overall, well-designed study. I think the most important takeaway that I have from this study is that vaccination doesn't seem to trigger GME, which is very important because especially nowadays, vaccinations get a bad reputation. But for anyone who's ever read the history of dogs, understands the importance of vaccinations, as it was thought dogs were going to become extinct in some of the more well-developed countries back during, I think it was the 30s or 40s, with distemper virus before a vaccination was made. So again, vaccination's extremely important, and at least in the majority of dogs, it doesn't seem to be a trigger. There's probably some to where it is a trigger, but finding what patient that is, we're not there yet. But all that said, good article, and that's all I have. Thank you.